Very good morning, ladies and gentlemen. I would like to welcome all of you on this bright Sunday morning for our webinar organized by the Society for Health Research and Innovation. Our topic today for discussion is very interesting and intriguing. Beyond the skin, dermatological manifestations of a systemic disease, a subject area that many of you has asked for. Just before going into the proper discussion, let us move into our regulations of this webinar. I would like to ask, as the courtesy of a guest speaker, to keep your microphones and videos totally switched off all throughout the time. As well as the webinar link will be available up until 9:45 a.m. to join in. No late attendees after 9:45 a.m. will be entertained. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points, and the CPD points are strictly adhered to the NCCPD guideline. This is to improve and also to maintain the standard of the CPD program conducted by Sri. As well as, I would like to remind you that if you have any questions regarding today's lecture, you can send us through a chat message. And at last, we would read them and get the answers for you from our distinguished speaker. Well, now it's a time to move on to the proper webinar. Today's distinguished speaker is Dr. Nayani Madarasinghe. Dr. Nayani Madarasinghe graduated from the University of Colombo with excellence and immediately enrolled to the postgraduate program in dermatology. She served as the former secretary for the Sri Lankan College of Dermatologists in year 2017 to 2019 also. So, I would like to humbly ask Madam Nayani Madarasinghe to continue with our important discussion today. Over to you, madam.
Good morning to all of you. So I will move on to my topic, that is beyond the skin, that is dermatological manifestations of systemic diseases. So as you all know, dermatology is a visual specialty. We mainly diagnose by taking the history and by looking at the patient and getting the visual impression. And sometimes this is aided by dermatoscopy and histology. Sometimes these skin manifestations will act just as a clue to the internal problems. Therefore, dermatologist is a team member in the hospital where we help the other physicians to manage their patients by giving the input. So these skin manifestations could be in various diseases, which can range from genetic diseases to multi-system internal diseases. So in my presentation today, I would like to take you through like case series in each of these disease entities where a dermatological manifestations has given a clue to the diagnosis of the skin problem, or sometimes just as a management issue where the knowledge of this existence of these skin manifestations are important for you all to manage these skin conditions. Case number 1 is a 1-year-old baby who was brought to the dermatology clinic with hyperpigmented skin lesions on the body. And the clinical diagnosis was ash leaf macules. So actually here, the differential diagnosis would be ash leaf macules, depigmented nevus, that is also known as achromic nevus and nevus anemicus, and also vitiligo. But depending on the distribution, the shape of the lesions, and also the number of the lesions, it was more favored toward ash leaf macules. And this was strengthened by the history that the patient has had a non-febrile fits in the history. So it was more pointing towards ash leaf macules. You can get like ash leaf macules in any person, but if it is more than 3, that is significant in number, and that will point towards tuberous sclerosis. So in this patient, we have examined, the eye examination was normal, ultrasound scan normal, 2D echo normal, but the CT brain showed diffuse cortical cyst-like radial-lucid areas. So the diagnosis of tuberous sclerosis is mainly based on these criteria, where you should have two major criteria or one major and two minor criteria. So in this patient also, tuberous sclerosis was diagnosed. So tuberous sclerosis is a genetic disorder that is characterized by hematomas in many organs. Usually it affects the skin, eyes, heart, and kidney. So in this presentation, actually, I'm not going into details of these individual disease entities, but just highlight the clinical, the dermatological manifestations that will aid towards the diagnosis of these disease conditions. So talking about other skin manifestations of tuberous sclerosis, this is known as shark green patch, which usually occurs on the back. This is a collagen nevus. And also it can occur in the face, which is known as the forehead plaque. And when it occurs on the forehead, that actually denotes that there is CNS abnormalities as well. And angiofibromas usually present later in in the childhood, and this is actually a mother and a son who was also having having tuberous sclerosis, showing angiofibromas in the face. These are persisting lesions, but sometimes due to cosmetic reasons, we can remove them by doing ablative lasers. So this was an example of skin manifestations in genetic diseases, that is tuberous sclerosis complex. Now we'll move on to the case number 2. It was a 42-year-old male who presented with a long-standing leg ulcer, which was painful, and there were past history of few small ulcers on the other leg. So the clinical diagnosis was pyoderma gangrenosum, and this was aided histologically. So pyoderma gangrenosum is a ulcerative, is a cause of leg ulcer. Usually, the leg ulcers progress very rapidly, and also they have necrotic edges, bluish and undermined edges. And the characteristic feature of pyoderma gangrenosum is it heals with paper-thin scars. So sometimes you can even diagnose get a clue to the diagnosis just by observing the scar of a pyoderma gangrenosum. And the presentation of pyoderma gangrenosum can vary. They can sometimes present as ulcerative lesions and even sometimes as bullous or vegetative lesions. The causes are widespread, it could be due to inflammatory bowel disease, chronic autoimmune liver disease, rheumatoid arthritis, Behçet syndrome, multiple myelomas, and leukemias. Therefore, if you diagnose the pyoderma gangrenosum, it is important that you look into all these aspects to see whether there's an underlying cause. So in our patient, there were no ischemic symptoms, but on direct questioning, he gave a history of episodes of mucus diarrhea in the recent months. All the other investigations were normal except for colonoscopy, which showed edematous mucosa and mucosal friability and few large erosions in the colon. And this was compatible with ulcerative colitis histologically. So the treatment for pyoderma gangrenosum was oral steroids, and this actually helped the mucosal diarrhea as well. Actually, I got a few questions earlier before this lecture, and someone has questioned about the response of oral steroids for pyoderma gangrenosum. Yes, that is something that will be very helpful in the management of pyoderma. And sometimes we give topical tacrolimus, and also intralesional steroids can be given. And if oral steroids are failing, then other immunosuppressants like cyclosporine and azathioprine are also given for pyoderma gangrenosum. So this was a skin manifestation of gastrointestinal diseases, that is a pyoderma gangrenosum presenting with association with ulcerative colitis. Now we will move on to the case number 3. This was a 51-year-old male who presented with a painful multiple ulcers in the legs for the last 1 month. He was also having fever, malaise, and loss of weight. So there were like palpable purpuric lesions as well, and ulcerations, and which are sometimes some were covered with necrotic bases. Depending on the size of the ulcers, a vasculitis and also a medium vessel vasculitis was suspected clinically. So actually, this is a clinical diagnosis. When you have palpable purpuric patches, we think of a vasculitis, and then we need to find out whether there's a cause for this vasculitis. So this clinical diagnosis was confirmed histologically, where there was vasculitis affecting small and medium vessels. So it was a medium vessel vasculitis. Talking about vasculitis, it is the inflammation of the vessel wall, and this can be classified according to the size of the vessel that is involved, like small vessel vasculitis, medium vessel vasculitis, and large vessel vasculitis. Although the classification is there, it doesn't mean that any of these diseases which will affect only these sides of the vessels. For example, if you take cryoglobulemic vasculitis, it will affect the small vessels mainly, but it can involve the other vessels as well. So talking about medium vessel vasculitis, actually there are only few causes like Kawasaki's and polyarthritis nodosa. And this patient, the history was pointing towards polyarthritis nodosa, and like with systemic examination showing peripheral neuropathy, and the blood pressure was high. He was not a known hypertensive. ESR was high, and serum creatinine was also high with 1.8, and the ANCAs were negative. The chest X-ray was normal. So according to the American College of Rheumatologists diagnostic criteria, a diagnosis of polyarthritis nodosa was made. And so you will appreciate that all these things presented, like the skin manifestations, paved the way towards the diagnosis of this somewhat rare condition, which is polyarthritis nodosa. So this is another example where skin and rheumatologic skin manifestations occur in rheumatologic diseases, that is vasculitis in polyarthritis nodosa. Again, in the questions that I received yesterday, so actually depending on the questions, I try to incorporate the other interesting areas to this lecture. So people have asked about the skin manifestations of rheumatoid arthritis. So again, the rheumatoid arthritis, you can have variable skin manifestations if we divide them histologically, like palisading granulomas, like granulomatous skin lesions can occur in lesions like rheumatoid nodules. Rheumatoid nodules are like firm nodules, which are usually seen in the extensor aspects and elbows. And these are mostly seen in patients with high rheumatoid factor. And then you have the neutrophilic dermatosis like pyoderma gangrenosum and sweets, which I will be talking about later. And then there can be vasculitic lesions. Again, there are various clinical presentations for these vasculitic lesions. I don't think you all have to go into that detail, but it is important that you know that these things can coexist. And also there can be skin manifestations related to the therapy that the patient is getting. So in broad categories, these are the skin manifestations of rheumatoid arthritis. Then the next case number 4A, it was a 62-year-old male who was otherwise healthy and who gave a past history of heavy smoking and alcohol consumption. And actually, the patient has had no symptoms, but the darkening of the skin was noted by a related doctor. And actually, this related doctor is none other than myself, and this is actually my uncle's story. So although he was asked to come for the investigations, he presented for the investigations only 2 months later. So when he came, he was having, initially it was the hyperpigmentation, but over the 2 months, the skin has thickened with velvety thickening of all flexures. The mucosa was normal, and also the palm, so actually a diagnosis of acanthosis nigricans was made. Talking about acanthosis nigricans, actually this is a very common condition these days, and there are various causes like obesity, we see a lot of acanthosis nigricans in people, especially children with overweight children, which is actually due to insulin resistance and polycystic ovarian disease, hypothyroidism, and there are some drugs which can cause acanthosis nigricans. So when like acanthosis nigricans is very common, and when do we suspect malignant acanthosis nigricans? That is then important questions, because we can't be doing investigations in all these patients who are having acanthosis nigricans these days. So rapid progression and mucosal involvement are two main factors which will point towards malignancy. And actually this patient had very rapid progression over 2 months, which was initially noted as hyperpigmentation, but over 2 months, it has progressed into profuse acanthosis nigricans. And the palms were also showing skin thickening with accentuation of the normal dermatographic ridges and sarcode. So this is a phenomenon known as stripe palms, and actually this is a condition, skin manifestation, where it is associated with skin internal malignancies in most or all cases. So this is this is known as stripe palm. Actually, it is not common. Actually, I have seen this only once. That is in this actually in my uncle. So then only we did the investigations, and over the investigation, over the course of the investigations, he developed loss of appetite due to the course of investigations. And the examination, there was a mass in the abdomen, and the ultrasound scan showed disseminated malignancy. And the upper GI showed fungating growth in the proximal part of the stomach, which was later diagnosed as an adenocarcinoma of the stomach. So actually, this patient passed away just after 3 months of the diagnosis of this malignant acanthosis nigricans associated with stripe palms. So this is another indication, like a manifestation of internal malignancy, acanthosis nigricans, stripe palms with adenocarcinoma of the stomach. Case number 4B, a 56-year-old male with 8 months history of generalized pruritus, treated with antihistamines with not much response. This is again a very common condition. We have to know the causes of generalized pruritus. So when examining, there are no primary skin lesions, but there are only widespread excoriations. So talking about generalized pruritus, the causes could be chronic renal failure, cholestasis, iron deficiency, polycythemia, malignancies like leukemia and lymphomas, thyroid disease, and lastly, it could be idiopathic. Especially in the elderly population, they can get a senile generalized, which is known as senile generalized pruritus due to dry skin, and there's no cause, but it has to be a diagnosis of exclusion. So in this patient, the systemic examination was normal, but except for the enlarged cervical and inguinal lymph nodes. And getting lymph nodes in a patient with generalized pruritus also may not point towards malignancy always, because when they have pruritus, they itch, they scratch their skin, and then you get excoriations, and then there can be secondary infections, so the lymph nodes could be enlarged. However, in this patient, the lymph node biopsy showed features suggestive of T-cell lymphoma. So this is another example of a skin manifestation associated with internal malignancy, that is generalized pruritus associated with T-cell lymphoma. So talking about skin manifestations of internal malignancy, there are different categories. Some are very rare, and those may be associated with cancers in most or all cases. So stripe palms, I have shown an example earlier. Paraneoplastic pemphigus is ulcerations in the mucosa, oral mucosa and other mucosal areas with targetoid lesions in the rest of the body. So actually, and then carcinoid syndrome, where you get flushing in the upper extremities, and necrotic migratory erythema and erythema gyratum repens. So all these conditions are rare, but when it is there, it can be associated with cancers in most or all cases. So actually, in my experience over the last more than 10-15 years with the training period, I have seen only one tripalm and one paraneoplastic pemphigus. So that means those are rare, and both of them were associated with cancers. And then there's another subset where there can be a strong association of cancer in a subset of patients like acanthosis, neutrophilic dermatosis like sweeps and pyoderma gangrenosum, and sometimes dermatomyositis. And then there are other conditions which could be associated with cancer. That is like things like acquired ichthyosis, cutaneous small vessel vasculitis, and even sometimes exfoliative dermatitis. And there's another subset which is associated with monoclonal gammopathies. So out of all these things, I think it is very important that to note that the ones which are more common, like things like acquired ichthyosis, cutaneous small vessel vasculitis, exfoliative dermatitis, acanthosis, all these are common, but still they stand a chance of having a connection to an internal malignancy. May not be in all cases, but in a very small percentage. So it is important that we pick them. So those are those are the patients that should not be missed, because these are common things, but they can be associated with a malignancy in a small subset of patients. So actually, this was again a patient who presented with these skin manifestations with erythema and telangiectasia. I don't know whether it is very, and she was also having erythema around the fingers, which was the periangle area, and at this point, it was only features skin features suggestive of dermatomyositis. Even the myositis part was not there. But when during the course of the illness, she developed myositis, and later she was diagnosed with ovarian cancer. And this was after chemotherapy. Again, she developed a relapse of the skin condition. And I think in this picture, you can observe the heliotrope rash, which is a characteristic feature of dermatomyositis. And these are like pyoderma gangrenosum and primary systemic amyloidosis, which is again like connected with the monoclonal gammopathies. And these are these skin manifestations are not directly taken when we are talking about skin and internal malignancies, but this is known as Sister Joseph's nodule, like cutaneous deposits, which can be with connection with the internal malignancies in the adenocarcinoma of the stomach, and this is a Paget's disease. So usually, which can where there can be an association with underlying breast carcinoma. So Paget's disease of the nipple is an important diagnosis, because this can be mixed as just an eczema. So like when they have atopic eczema in childhood, it is very common for them to get nipple eczemas as adults. But then if the eczema is unilateral, you have to always suspect whether it could be a Paget's disease, and doing a biopsy would be helpful to diagnose this. So now we will move on to another entity, that is case number 5. That is a 66-year-old patient with a known patient with stage 4 chronic kidney disease. He presented with generalized pruritus and papular skin lesions. So as I mentioned earlier, generalized pruritus is common in patients with chronic kidney disease. There are various causes for that. And in addition, he was having these papular skin lesions. So the clinical diagnosis was perforating collagenoses. And this was confirmed by the histology, where there was, actually this is a rare disorder, where there is transepidermal elimination of altered collagen through the epidermis. This can be extremely itchy. So actually, sometimes the patients are suffering more from the skin disease like itching and these conditions rather than their chronic kidney disease. So again, this is a skin manifestation related to renal disorders, that is perforating collagenoses. So usually, like when it comes to skin manifestations in chronic kidney disease, unlike in the other case scenarios that I mentioned, these will not pave a clue to the diagnosis, but it is important that you know that these things exist. So talking about other skin changes that you can see in chronic renal failure, that is they can get hyperpigmentation, dry skin. So like, I mean, you have to relieve the dry skin, otherwise the pruritus can be more severe. And then they get nail changes like half nails, and then rarely this perforating collagenoses. Like symptomatic control of these skin manifestations would be important to make their lives comfortable. Then we will move on to case number 6. That is a 56-year-old male who presented with generalized hyperpigmentation, and he was also having buccal mucosal pigmentation. I think this is a straightforward scenario where you must be thinking about the diagnosis even at the moment. But what are the other causes of hyperpigmentation? So like there can be multiple endocrine causes like thyroid dysfunction, Addison's disease, hemochromatosis, and then you get nutritional deficiencies like B12 deficiencies, and renal and liver disease, sometimes drugs, and malignancies. So when a patient presents with hyperpigmentation, especially depending on the distribution, sometimes there will be a clue to what it is properly, but otherwise we might have to do the investigations to work out the cause of this hyperpigmentation. So in this patient, he was also having fatigue and muscle pain and loss of weight and low mood. BP was low and the muscle power was low. And the investigations were pointing towards Addison's disease. So this is a skin manifestation of endocrine disorders. That is a generalized hyperpigmentation in Addison's disease. So in Addison's disease, the hyperpigmentation which occurs in the buccal mucosa and also along the skin creases are characteristic. Again, this is due to a question. I included this, like people have asked about the skin manifestations in diabetes, like acanthosis nigricans is very common, like even in the pre-diabetic stage. This is actually a manifestation which comes with insulin resistance. So we can warn people that you are going to get diabetes in the future. So like do the lifestyle modifications. Actually, this advice should come from the patients. Even in our practice, people mostly come with darkening of neck, like they come to us due to the cosmetic reasons, due to darkening of the neck or the armpits, but we should take the time to advise them about the possibility of having insulin resistance and diabetes in the future and warn them accordingly. And then you can get multiple infections, mostly bacterial infections and sometimes fungal infections, and diabetic ulcers and diabetic dermopathy. This is actually the most common skin manifestation in diabetes. That is that you get hyperpigmented macules, mostly on the legs, which can be atrophic. And then you have this necrobiotic lipoidica. Actually, this is a picture taken from the internet. Here, like, although this is a very well-known association, it's only a rarity of patients with diabetes will develop necrobiotic lipoidica. But in people with necrobiotic lipoidica, there's a more chance of them having diabetes. It's like that. So it's firm reddish papules which lead to atrophic plaques on both chins. And the diagnosis can be confirmed with the histology. Then again, there was a concern about thyroid disease and skin manifestation. So both hypothyroidism and hypothyroidism can cause skin manifestations. Alopecia is seen in both conditions, and hyperhidrosis, petechial myxedema, palmaerythema, and onycholysis are seen in hyperthyroidism, where in hypo you get dry hair and dry and coarse skin. So sometimes again, these skin manifestations, like a patient with secondary ichthyosis who is coming with the complaint of dry skin, if you do a TSH, it can point towards hypothyroidism. So this is the importance of knowing these skin manifestations with associations of systemic diseases. We will move on to the next case. That is a 64-year-old lady who was presenting with acute onset fever, malaise, and this painful erythematous skin lesion. This is a very acute onset, short duration problem. So the clinical diagnosis was a Sweets syndrome. Sweets syndrome is a neutrophilic dermatosis. Yes. In this patient, the investigation showed high ESR and also a neutrophil leukocytosis. And the histologist revealed a heavy upper dermal infiltration of neutrophils. And the patient showed a rapid clinical response to oral steroids. And both with actually there are diagnostic criteria to diagnose Sweet syndrome, but just by looking at it we can suspect that, and aided by the other investigations and also rapid response to steroid also comes with the diagnostic criteria of Sweet. So in this patient, Sweet syndrome was diagnosed. So talking about Sweet syndrome, it is a neutrophilic dermatosis where there will be heavy infiltration of, it's a dermal disorder. So there will be heavy infiltration of neutrophils in the upper dermis. And sometimes these lesions can ulcerate and cause blisters as well. So talking about the causes, it could be idiopathic, which would be the majority, but it can be associated with infections, especially the streptococcal sore throat, and some drugs, and inflammatory bowel disease, and hematological conditions like leukemias and myelodysplasias. Going back to our patient, she had the blood picture showed leukemic blast cells, and bone marrow showed confirmatory evidence of acute myeloid leukemia. So this was a patient who was presenting with a skin manifestation, that is Sweet syndrome, and an underlying hematological malignancy leukemia was diagnosed based on that. Case number 8, 54-year-old patient, heavy alcoholic, who was presenting with dry scaly rash on photoexposed areas. There was weight loss and malaise also. Looking at the clinical pictures, pellagra was diagnosed. It was due to vitamin B3 deficiency. And this is again another nutritional deficiency, which is actually I'm giving the diagnosis beforehand. So yes, this is a 4-month-old baby who was presenting with erythematous rash around the perineum, and the clinical diagnosis was zinc deficiency. Usually, they present during this stage during the weaning period, and they also show a very rapid response to zinc supplements. The rash disappears very quickly. So skin changes in zinc deficiency could be periorificial, well-demarcated dry scaly rash, alopecia, and rapid response to zinc supplements, as I mentioned earlier. And also, in addition to the skin changes, they can have diarrhea and failure to thrive. This is another baby who was having failure to thrive, and on examination of the skin findings, he was having edema, pale skin, and dry brittle nails. Actually, this was the diagnosis of kwashiorkor. So you can see that there are several skin manifestations in association with nutritional disorders, and I have showed few examples. Case number 9, we're actually going towards the end of this presentation. It is a 63-year-old female who presented with an itchy skin rash with feeling of insects crawling on her skin. And when she tries to remove them by picking, picking her own skin, which leaves a mark. So actually, this is somewhat different from all the other presentations that I described earlier. So when we examine, there's no primary skin lesions, but there are only excoriations. But she always gives this history of insects crawling on the skin. So this is a diagnosis of, yes, there are no primary skin lesions, and there are secondary skin changes like inflammatory hyperpigmentation due to the self-inflicted skin damage. So the clinical diagnosis was delusional parasitosis. Actually, this is a psychiatric disorder where they believe that there are insects in their skin, and all the skin changes are due to secondary self-harming things. There can be anxiety and depression underlying, Therefore, actually in this patient also psychiatric referral was done, and she was then treated for depression. So it is very common for them, like this is known as matchbox sign, which is interesting because they themselves bring like their insects which they found on the skin. They claim that these are insects, but if you examine them, it is actually skin debris. It is this is known as matchbox sign. In our culture, sometimes they just get these things in wrapped in a paper or a newspaper, or sometimes in a small plastic container. So this is all just the skin debris that they think as insects. So it is actually a skin manifestation in related to psychiatric disorder, which is known as delusional parasitosis associated with depression. So we are moving on to the last case, that is case number 10. A 27-year-old male presented with the painful lumps in both legs for the last 3 weeks. This was acute onset. He was also having like malaise and joint pains. And the clinical diagnosis, I think you can also make this diagnosis, it's an erythema nodosum. So what is erythema nodosum? Erythema nodosum is actually a non-specific cutaneous reaction. There can be various causes for this, and they usually present with tender subcutaneous nodules, mostly in the extensor surface of the legs, and there will be a spontaneous resolution, like within 2 to 3 weeks they can resolve, but sometimes again it can recur after some symptom-free period. And this is mostly seen in women. If we do a biopsy, it will be a panniculitis, which is a septal panniculitis without vasculitis. But as I said, it is a non-specific cutaneous reaction. Therefore, it is important that we do the proper workup to diagnose the underlying cause when you see a patient with erythema nodosum. Actually, this sometimes it's going to be very difficult because this can happen with various infections, be it bacterial infections, fungal infections, viral infections. All these things can sometimes give rise to a erythema nodosum as a reaction. So tuberculosis, leprosy, all these infections are there, and it can be due to drugs, sarcoidosis, inflammatory bowel disease, and sometimes malignancies like leukemias and lymphomas. I think you may notice that inflammatory bowel disease and hematological malignancies are also, like both of them are linked with a lot of skin manifestations. So yes, it is, although it is a self-limiting condition, it could be very painful. Therefore, the patients will be like, should be managed symptomatically with bed rest and non-steroidal NSAIDs. And before giving steroids, it is very important that we exclude the cause for this. Like sometimes it could be an underlying tuberculosis as well. So in this patient, she was also having systemic cervical, enlarged cervical lymph node. The rest of the systemic examination was normal. ESR was 55, and the lymph node biopsy showed non-caseating granuloma. So this was pointing towards a sarcoidosis. The mount was negative, and the serum ACE levels were high, also a feature seen in sarcoidosis. So a diagnosis of sarcoidosis was made. So talking about sarcoidosis, it is a multi-system granulomatous disease. The skin is the second most organ which is affected. Like in about 30% of the patients with sarcoidosis, there can be skin manifestations. And the other organs which can be affected are lung, lymph nodes, eyes. Actually, like there is a multi-system involvement, and you can see non-caseating granulomas in the tissues. Yesterday from the questions, there was again a question about whether there's a connection of sarcoidosis and internal malignancies. To say that there are, like, I mean, there are very rare case reports reported, but there's no major association of sarcoidosis and internal malignancies. So talking about cutaneous manifestations of sarcoidosis, actually there's a wide range. It could be a great mimic of any other skin disorder. So it can manifest as small multiple small papules in the skin, or sometimes like plaques. Lupus pernio is the erythematous plaque which is occurring in the nose, and also this scar sarcoidosis, like erythematous plaque-like lesions occurring in scars, is a characteristic feature of cutaneous sarcoidosis. So, whenever you suspected a skin lesion to be like a sarcoidosis, actually this will be a differential diagnosis only, because we can say it's a dermal lesion. So there are other differential diagnoses also will come into play. So we will have to do a biopsy, and the biopsy will point towards sarcoidosis here. So this is an example of a skin manifestation in multi-system disorder, that is a erythema nodosum presenting as in sarcoidosis. So I think I have covered all these several systemic disorders which can have associations with skin manifestations. I think this must have given you some idea how important the diagnosis of a certain skin disease is, because it can give rise to it can pave the way towards a diagnosis of a multi-system disorder or an underlying malignancy even. So the take-home messages will be like the skin manifestation just could be the visible sign of the internal disease. So therefore, it is important to know the associations of these to diagnose them early. And also, even if it doesn't pave towards a diagnosis, it is important to know the association, because that will help in the management. So whenever you see a skin manifestation, and if you think that there could be an association, you can get the dermatologist's help. So I think you must have realized that dermatology is not just skin deep. Thank you.
Thank you very much, madam. It was really intriguing as well as very informative, comprehensive lecture that we had today. So now I would like to first of all show our gratitude and say thank you very much for our distinguished guest speaker, behalf of the Society for Health Research and Innovation. Thank you very much for coming today to our sessions and enlightened all of us regarding these dermatological manifestations. We had almost around 20 questions. I do not think we do have time for all the 20 questions, but I'm sure Madam will be happy to answer few of them randomly. And the other questions which will not be answered today will be answered by an email for this by email for the personal emails. So first of all, we would go to the first question, which is sent by Dr. Asif Farooq. Where is the typical location of pyoderma granulosum ulcers, madam?
Actually, these are mostly seen in the lower legs, but there's no typical location, because pyoderma granulosum can sometimes occur in the upper limbs and sometimes even on the face.
Okay, madam. And there's another question. Can lupus vulgaris cause carcinoma?
Yes. So actually in this presentation, I have not touched on the skin manifestations in relation to infections. Actually, like there were several questions on it also. So lupus vulgaris, for the people who don't know, it is it is a cutaneous type of cutaneous tuberculosis. So when these lesions are persistent, there's a small possibility of them turning into a squamous cell carcinoma.
Yes, another question by Dr. RMN. Can we consider polymyositis also as a paraneoplastic condition?
Polymyositis per se, I don't think it is when you say paraneoplastic conditions, those are like where you have like certain skin manifestations, and in association there could be an internal malignancy. So the ones that I mentioned earlier, like the tripalms, erythema gyratum repens, those are the things which are known as like paraneoplastic condition. But in polymyositis, there can be an association, but it doesn't it doesn't come into the clear entity of paraneoplastic condition.
Okay, thank you, madam. And there's another question regarding the baldness of a female of a 52-year-old. Can it be due to a systematic cause?
Yeah, this is again, I haven't touched on that, like female pattern alopecia is very common, like, I mean, uh, but uh, it is usually due to like genetic causes and other hormonal issues like polycystic ovarian disease. But actually, I have seen one patient who was having this female pattern hair loss, and she was also having the other features like, I mean, pointing towards testis, like androgenic excess. So then when she was investigated, this turned out to be an ovarian tumor. So in that regard, like if a patient is having androgenic alopecia, and if it is like, I mean, fairly extensive and like not according to the age, then we do the workup to see there whether there are any underlying causes, and there can be rare associations of this being associated with the androgen secreting tumor. So in summary, there can be an association.
The next question is from Dr. Hasini Jayasundara. Does zinc deficiency cause photosensitivity?
That, of course, I'm not very sure. I have to check on it.
Okay, for the last question for today, madam, what could be the systematic reason for persistent folliculitis?
Persistent folliculitis, yes. Like like you have the community acquired MRSA infections where you get skin and subcutaneous bacterial infections like furuncles. But persistent folliculitis, it is there, like, I mean, it is happening as a idiopathic for idiopathic reasons, but sometimes certain habits like shaving, like the wrong methods of shaving, which can irritate the hair follicles, can lead to folliculitis. That is the infection around the hair follicle. The MRSA, community-acquired MRSA is multiple furunculosis.
Thank you very much, madam, for this very innovative and very timely topic that we've discussed today. So once again, our sincere thank goes to Dr. Nayani Madarasinghe, consultant dermatologist at the Colombo East Base Hospital, Mullaeriyawa, for her excellent lecture and the precious time that you have spent with us. So for all the questions that we could not answer today due to the time limitations, we will be sending you personal emails with the answers from Madam personally. And also, I would like to remind you that the link is there on the chat box. Please do go and click on the link and give us your feedback. There will be a post-assessment question test also. And with that, you can receive the e-certificate for the participation. On behalf of the Society for the Health, Research and Innovation, I would like to thank once again Dr. Nayani Madarasinghe, Madam, to come here today and give us with your wisdom, and also all of you for joining in this Sunday morning. I would like to conclude this session by reminding you, please do join with us next Sunday morning also for a very productive and informative session just like today. Thank you very much.